we'll start because it's already 5, and this is the format we follow as was given in the program by Dr. Partha Viswas so well. And so we have 10 minutes, but we can also, the discussions in the end, but we can have 2 minutes discussion, couple of questions for each speaker after each presentation. So I'll request our first speaker, Dr. Chaitra Jaydev, to please start. I'm stopping the sharing.
Thank you, sir. I'll just share my presentation.
Sure, thank you.
Right. So good evening, everybody. I must thank sir for including me in his, Master IC. This is a pleasure to be here, and with so many important talks here, I'm sure we'll all be able to learn a lot more at the end of this session. I will be speaking on evolving retinal imaging techniques. That's rather a vast topic. I'm going to try to quickly go through a couple of them actually, because it's impossible to cover all of them. No financial disclosure. So 3 main things that I would be talking about today, which has evolved so much over the time, is ultra wide field imaging, multicolor imaging, and Octa. These are some things that we use in our day-to-day practice. Coming first to ultra wide field imaging, so we have the slit lamp giving us 90 degrees. Then we have the 30 degrees indirect, the 45 degrees with our regular fundus cameras. And then we have wide field on giving us up to 100 degrees. And finally, the ultra wide field up to 200 degrees. So this was the revised classification by the International Wide Field Study Imaging Study Group, which showed us what actually the ultra wide field covers, where we're able to see anterior to the vortex mean and all the 4 quadrants. So it describes imaging up to the periphery in a single capture. Traditional retinal imaging does not offer this complete view. We need to at least get 4 to 9 image montages, and they're usually limited to the area, around the posterior pole. And wider field cameras, therefore, offer increased visibility. And this helps us to document over 80% of the retina in a single capture. As you can see here, there is just one, there is a montage here which is showing, and you can see there's so much of overlap, and there is loss of sometimes even detail compared to the ultra wide field imaging. And here we're seeing some other lesions and conditions that have been montaged together, and we can miss out some important findings. Some more images again of montaging and just of the posterior pole. So if you could just get all of it in one view, it would definitely be advantageous. Now, how are the advantages as far as ultra wide goes? It can be taken through most of the cataracts and vitreous opacities, also the newer devices. Even in non-mediatric pupils, even through 2 millimeter pupils, we've been able to get fair amount of details. It's fast, it's comfortable, and convenient for most of these patients. They have multiple imaging modalities as well, and you can use overlay to compare and monitor eye health. Also, images are available for immediate review. We don't need to wait for any processing, and also a good patient education tool for most of us. So this is how an ultra wide field image looks. It also has FAF, where we can use fundus autofluorescence and green light laser and visualization of the RP changes as well. So these are some of the images that have been provided, but then quite useful in day-to-day practice also, especially when you're looking at the peripheral retina. This is a picture of a choroidal melanoma. Now, some other examples in retinal diseases, especially in diabetic retinopathy, although it predominantly affects the posterior pole, we do know that periphery is very much involved, and that could be missed with standard imaging. So this is one patient where we've imaged and seen the progression over time. Though the patient had been well lasered, we can see how the disease has become extensive, and subsequently with treatment and surgery, how he has improved now. Other vascular diseases also can be very well imaged. Peripheral ischemia and neovascularization, you can use ultra wide field angiography to detect it. These are some other images that show the severe extent. This is a patient with hypertensive, choroidopathy, malignant hypertension patient whom we could image very well. Inflammatory diseases also, just when it's beyond the posterior pole, we do get a lot of visibility here. You can see this is pre and post laser, how the disease resolution occurs. I find it very useful to show peripheral retinal degenerations to our patients before treatment, because they do tend not to believe you when you say you have this tiny hole or this tear that can give rise to detachment, and then there is this factor where they can understand why this particular treatment is being done. This is a patient with a reg Gardi where you can see clearly, and also here pre and post laser to show them that we actually did. Sometimes they say, doctor, it just took about 10 minutes. Did any treatment actually happen? AMD beyond the retinal, beyond the posterior pole also can be imaged here. These are some of the patients with peripheral PCVs with PSCR also post-treatment. We are able to demonstrate response to treatment. This is a posterior pole massive hemorrhage with migration of the blood inferiorly and subsequent follow-ups as well, the scarring. Important in pediatric retinal diseases, sometimes it's impossible to capture it in a single take. So this does help with ultra wide field. We're showing the different pathologies here, some dystrophies as well. These are some congenital anomalies, and like I mentioned, dystrophies are good to document here for progression as well. So enhanced resolution, shorter image processing time, faster image acquisition, ease of image duplication manipulations if need be for any purpose, possibilities of transmission through electronic route, better acquisition through eyes with cataract, and like I mentioned, pediatric patients, very small pupil, uncooperative patients, it is good. And like FA and ICG and FAF is already enabled in some of these devices. But it is difficult to precisely measure these images. Sometimes artifacts are common, pseudo color and optos, and the cost of acquiring is high. Going on to multicolor imaging, I'll have to rush through because there are a lot of slides here. We do have the multiple, lasers here that we can get information from the difference. With blue reflectance, we get the superficial, then green, and the deeper through the red reflectance. Here's the epiretinal membrane seen beautifully, some drusen, choroidal folds, vitromacular traction. Here, the comparison between the fundus and the confocal multicolor, where you can see such good detail. Ischemic maculopathy also can be very well visualized, very similar to the FFA. It identifies the level of the lesion, topographical information. We have blue roll in hazy media, subtle lesions, and functional information also, and all of this non-invasively. So some more examples here of the ERM and how well it can be delineated topographically. You can mark it out so well as to the extent of the lesion. Also, with color fundus imaging being today's standard, I think there is a possibility that multicolor could be tomorrow's standard. Now, some of the policies are it does take a longer time to fixate artifacts again, and sometimes we get something called as ghost artifacts with underage pupils. Now, going on to Octa, we've seen a rapid evolution, and we're very, very happy from, is Octa actually required to? Yes, we do use Octa in our day-to-day practice. We have seen good evolution. There are different machines using different algorithms. Just coming to some of the recent advances, this is the Plex Elite, where we're getting, up to 12 millimeter scans beyond what we're seeing. And we're also able to montage these images to better diagnose and treat and monitor our patients. This is quickly one patient with BRVO on the Spectralis Octa. It's beautiful where you can see the 3D imaging and the non-perfusion areas as well. This is another patient with a type 2 CNV where if you see, we have used FA, ICGA and multicolor Octa, where the 3D image actually shows us the depth of the lesion here very, very well. So this is limited to the posterior pole as of now. It is also dependent on the speed of the blood flow. Learning curve is very high in this, and also, manual segmentation is needed. And as we all know, Octa is fraught with artifacts, which we have to find ways to overcome. Some of the functional OCTs that are in the process, the Doppler OCT, and this is a polarization sensitive OCT. Our center is also, building one, and I'm hoping to present this in our future meeting sometime. Thank you so much. So I can't hear you, sir.
Yes. So it's a very, very nice presentation with a lot of thoughts and ideas behind the images, and what the present has and what the future holds. So it's important that to understand imaging is right now, retinal imaging is undergoing a major revolution. So I'd ask Professor Dogra, expert opinion, and Professor Vishali's expert opinion as to what they feel would be the future of imaging, like multicolor imaging and this Octa, the future of all these things versus the already traditional imaging of FA, ICG, and standard color photograph?
I think Chetra has very nicely demonstrated various examples, as well as what all we can do with the wide field imaging. In fact, I think if you have a wide field imaging and a lot of these octas available, even just images, and somebody requires images for you, maybe you don't need that kind of extensive examination, and you will have everything in front of you even before you have had a look. And maybe you'll pick up more on the image than perhaps sometimes you may miss even on examination, because it may be patient cooperation oriented. So
Right.
Another one which she mentioned very nicely is very, very important to document and to show all these things in today's time, whenever such advanced procedures are being done for refractive surgery, for other things, that, well, what are the issues in the periphery? And of course, there's so many things which she talked. So I think this is the future, and it is going to become a part of examination. If these machines are become affordable, then they will add and help, and we'll be at much at ease. That is what my take is on this.
So, what points? What do you think about fever? Do you think it's possible to, because Chetra is also into their centers into pediatric retinal diseases. So you also been through your life, you spent your time in pediatric retinal disease. Fever is something which is only there in the periphery. And
yes,
what do you think? I mean, like with the wide field imaging, the future would it improve the prognosis?
Absolutely. I think I didn't name the diseases. Fever will come in front, and fever is very common in our country.
Yes.
And we are going to that's what I'm saying. We are going to diagnose more conditions if we use these wide field imaging in routine, and we'll pick up these cases very fast, and we'll be able to diagnose all these kind of problems where we are. Even what is, of course, going to also happen is, since the wide field imaging is there, the people are not even going to do indirect ophthalmoscopy and other things. That is what also would happen probably down the line, because now they'll be able to image up to ora serrata. So you are absolutely right. And that is how we will manage them better and timely. And we also get angiograms, wide field, which is needed. That is why fever can be treated right in time if we have an angiogram for periphery.
Before the detachment occurs.
Yes, absolutely. Because that is usually around puberty. You have seen there is a sudden worsening in these cases.
A sudden worsening. Yes. It can be there throughout life, sir.
Yes.
We don't have the FFA. I think one major, ultra wide field angiography, I think sir will agree, is really fantastic, because, we tend to have to steer the camera around, and for particularly peripheral disease, I think to get it at a single shot with angiography also is excellent tool to have, but we don't have the ultra wide field angiography.
I think the newer ones with the which has got everything, they even have OCT. So I have not had a look at it, but I think that has got everything.
That's a Optos Silverstone.
Yes.
After the California.
Yes, absolutely.
We go on to the next presentation. So I'll be sharing my screen and request Professor Mangadogra to be the moderator.
Thank you, Professor Atul. Please, we are looking forward to your talk.
Audiovisual may kindly fix the time correctly. It's 10 minutes. You've set at 8 minutes. Yeah, thank you.
So I'm talking a little bit about macular pathologies, which we get to see a lot more, because we possibly again because of better imaging tools and modalities available to us, and sometimes the wrong interpretations which we're doing because of multimodal imaging have improved. So this I'm just showing you the various macular pathologies, surgical macular pathology. This is how the Ingenuity 3D viewing system is. So this is another imaging modality which just helps you to see, and it's got pixelization, and so it's a digitized image and gives you 3D exposure, and the surgeons as well as the students would get to see exactly through their passive polaroid glasses. They also see the surgery as the surgeon would see. I'll talk about one of the entities which we were probably missing out before because of improved imaging. Even the SDOCT can pick up all these findings. It need not be a swept source OCT, and the SDOCT or swept source OCT would pick up these myopic traction maculopathy. I get to see it day in, day out in so many patients who are myopics, and often we just asked to follow up because they haven't progressed, but some of them do progress. They develop a hole in the center. This is a compound schisis which is there. So we need to have a serial follow-up of these patients because they tend to worsen, and then when they worsen again, just like fever as sir pointed out, we need to take care of them much before they actually develop a detachment. So much before. So imaging really helps. So Chaitra has laid the foundation of what is important for this course. And this is a patient who developed a macular hole in the myopic patient. And what we did was the OCT picked it up very well. So the same patient, the OCT, the intraoperative OCT really helped to pick up the hole again and to localize the hole. So the posterior hyaloid with the triamcinolone, which is dusted onto the posterior hyaloid, because these pathological maps, you may have adherent vitreous. So which may, if you remove the vitreous, you actually do a vitreous schisis. So to make sure the entire vitreous remove, you must put some triamcinolone crystals. So there you can see the hole exactly centered, and you can put through the light reflex, you can see this Ilm is peeled with brilliant blue G dye, and the hole, once the hole is closed, you are dead sure on the IOCT device which is there. This is integrated IOCT, and this integrated IOC will show you that you are actually, once you close the hole, you're dead sure on the IOCT, then only do you put in gas. The 3D device also, there's less asynopia because you're looking at a distance, not exactly to the microscope eyepiece. Now, I'll come to I'll just cover a few common diseases. So, like macular hole, I just did, and the myopic. So, epiretinal membrane is grade 0, grade 1. We should not actually do it, but so peel or not to peel is the question mark. We shouldn't peel every hole, and only if a patient develops symptoms, he's got metamorphopsia, and his vision's dropped, and he's feeling symptomatically worse. So you need to do serial follow-ups of such patients. Sometimes they develop a pseudo hole because the traction is so severe, they develop a hole. This just saw yesterday one patient. He developed a pseudo hole in the center because there were thick ERM on the OCT, which actually tore the retina in the center and developed a pseudo hole. So he was very symptomatic. He said, "I'm missing letters and I'm seeing distorted on the grid, Amsler grid." So once you see this kind of a picture, then of course one should consider surgery. Till then, I think one should hold their hand and consider conservative management and probably just follow up the patient regularly with the OCT. So this is a patient who had a symptomatic epiretinal membrane. Once he had a symptom, again we used triamcinolone also to induce PVD. Besides PVD induction, which is in the first most important step, you then scored some brilliant blue G dye. The epiretinal membrane will not stain, but of course the background ILM will stain. So once you get negative staining, the red color is actually the membrane, and this is, all these videos have been converted to MP4. So the slide, this thing, you can see that the thick ERM has been removed, and some part of the ILM does come off with it. So I'm not in favor of doing too much of peeling at double dye and second time again remove ILM. Once you remove the ERM as a sheet, I don't think there's any need to go back again and do surgery. So most of my ERMs, I just do the initial proper ERM surgery as a single sheet or a double. I mean, 2-3 layers, 2-3 pieces does come off. Once it comes off completely, then I don't do the second part of it, which is the ILM peeling, put some retin blue, put the brilliant blue. I mean, all these various dyes, no. And also ILM peeling in such cases may actually damage the macula more than he would actually have his vision the quality of vision may be much better before surgery. So I removed the ERM and that's it. Put some gas, short acting. Ask him to sit propped up. So macular holes I've already told you. So this is just a patient who had a macular hole with SRF. The hole appeared to be slightly different on the surface OCT, as if somebody's pulled up the retina, and we found a VPT, vasoproliferative tumor, sitting at the periphery. So we actually spent some time, few months, lasering the VPT to make sure all the exudation from the VPT got taken care of, and then only repeated the whole surgery. So whenever you see a macular hole, just don't straight away get excited and do the surgery, because you might have something in the periphery also, and it's important to see it. So I'm talking about my submacular deep displacement. I combined this is something because of increased incidence of probably more better imaging modalities with picking up the polypoidal choroidal vasculopathy. We're seeing those ICG, more of ICG being done, but OCT octa also being done. We're picking up the polyps, we're picking up branching vascular networks on the OCT, and the OCTA shows the BVN very well. OCT also shows the polyps and the thumb-like PEDs. So the OCT actually gives you a wealth of information about the PCV patients, and surprisingly, none of the studies, the Everest Planet laptop study, involved India, where there is such a high incidence of PCV all over India. So I was shocked that we actually are not part of it. So anyway, I like to use the TPA, which is available as Actilize from Boehringer and all, and throughout India it's available as a dose of 12.5 micrograms, 0.1 ml. I give about 0.2 ml. Avastin I give double the dose, 1.25 milligram is the standard dose. I give 2.5 milligram. It's 0.1 ml plus some air, 0.2 cc of air. This is the 41 gauge translocation needle, the same needle which was used in Europe to create macular translocation. Is used because it self seals the this thing, retinotomy. The retinotomy is self sealing, and never had, at least in my hundreds of cases, I've never had a retinal detachment. So it really does self seal. So this is actually the ICG on a patient who had a massive bleed, and these bleed patients always show up the polyp very nicely. And you can see probably polyps too here, probably a ruptured polyp. A lot of hemorrhage, and the whole retina is lifted up, some PD over here. So multiple PEDs, typical of a PD patient, typical of a PCV patient. So all this comes under the pachychoroid spectrum. One end is the central serous choroidoretinopathy, CSCR, and the other end is the PCV. So we just go in, and supratemporal part of that, we put in a entire cocktail, and the air is in the end, so that may not come out. It may come out, but the air coalesces together in the end, and so you get a blister-like formation like this once the whole cocktail is inside, and that's the end of surgery. You just put in some air. I put little gas, SF6, and prop up the patient. And usually results are very exciting, and patients Whitefield octa also show Whitefield image also shows that the blood has moved away from the center, and it's kind of trickled downwards, and the OCT also shows just the PD left, PD, and a little bit of a double layer sign, which is indicative of a branching vascular. Now these patients should be followed up because that's not the end of this patient. They 25% incidence of recurrent bleeds. So and they develop the re-BVN and all that. So though I put Avastin inside, that is just for the short period. So just this week I had another patient who had been treated before with this cocktail treatment, and we had to rechecked. We rechecked, and with ICG and OCT, we saw that he had developed subretinal fluid, as well as some evidence of this thing, branching vascular network. So we re-injected him. On the octa, he had branching vascular network. Thank you very much.
Thank you, Professor Atul. You have very nicely shown various conditions involving the macula, especially which are amenable for surgical treatment. I think one of the things which we have trivialized and it created a problem, at least I have seen some patients, is about the epiretinal membrane.
Yes.
Sometimes the surgeons are going in even in the asymptomatic, even if they have still a good vision maybe 6/9, 6/12, and they are not complaining. And what I have seen is this: I have seen recently in some patients from outside where they formed a hole after removal of the epiretinal membrane. The vision came down to less than 660. So you see, the patient is so unhappy, he has never been told. So once that happens, I think one has to be very, very careful. I think we should not be taking these things very, very lightly. Sometimes these kind of retinas, they've been like that for a long time. They have little schitic areas there. We have all seen that. But if the patient is not symptomatic, I think we should not be. That is what my
to hold our hands, definitely.
Yes.
We should not be operating every ERM or every. So it's important to hold our hands, sir.
Yes.
And the patient comes for dry eye treatment because he's complaining of some itchiness. And he ends up in the whole circle, which was not even his complaint.
Yeah, but they are extremely unhappy. I had a big problem with one of the patients, and I could only console him because I told him that, well, nothing in this universe, even if you do get an injection, you may get a reaction and patient may not live, even die. So you have to take in that context. That is what I had to, because the patient was so unhappy. He wanted to go and sue the person and all that. They can be very, very unhappy at times if we are not. Yes.
Sir, can we go on to your talk, sir?
Oh, yeah. Yes. It's my, sorry.
So I would just like to say in the previous talk, what sir had shown the cocktail for the submacular blood. So I've been very fortunate to see some of sir's cases, and like sir said, the results are extremely dramatic and very excellent. Like in few days, we can see significant resolution of the bleed and very good recovery of visual acuity. I think that is a technique many of us should start learning.
Thank you, Rohan.
Absolutely. Very good. Okay, at the outset, I would like to thank Professor Atul Kumar for including me in his course, which I've been doing for so many years. And I'll try to go over one of the most common conditions which we face day in, day out: diabetic macular edema, the treatment options, and the managing kind of a recalcitrant diabetic macular edema. And I think DME is a chronic disease which requires long-term strategies. Since the pathogenesis is multifactorial, we require multimodal approach. So I always emphasize that the first thing when we see a patient, very first day, write down the investigation, tell them to get investigated: blood glucose level, blood pressure, lipids, hemoglobin, HbA1c, 24-hour urine protein, blood urea, and serum creatinine. As well as that very day, we can always do these days at least fundus photo and OCT. Maybe FFA can be done subsequently as a baseline, or sometimes it may or may not be required, but still in most of the diabetic DME patient, we do FFA also these days, although the use has come down. And after this, we have to achieve in them excellent glycemic control, normalize the blood pressure, and reduce the serum lipids. I think this earlier, Professor Atul has also emphasized that the lipids are very, very important. We have to treat anemia and proteinuria. We have good drugs for these. I think we have to talk to our these physicians or diabetologists that they should do everything together. I think I am showing you one very, very old patient here, that how the things would melt just in 3 months' time. If you have a good, strict metabolic, not only blood sugar, lipids, their proteinuria, everything goes down. This is without anti-VEGF and laser. That is what is required. So what are the treatment options? That is the basic topic. The treatment option for DME at this time are anti-VEGF agents, which we have 3: ranibizumab, aflibercept, and bevacizumab. Of course, we have steroids, dexamethasone implant, fluocinolone, we don't have, Iluvien, triamcinolone, 2 of them. Laser still we have, and the laser use has come down. And this laser I'm not talking also much, but we do it in routine in many of our non-central involving DME. And of course, there is a role of surgery in cases of DME. So basically, we have these bevacizumab, ranibizumab, elpiprecept, or biosimilars. A lot of them has come, and all of them, they improve the visual acuity, decrease the macular thickness in DME, but the effect is temporary and repeated injections are required. That's where the problem is. I think the whole which anti-VEGF to use, that is always a question. So protocol T, which was over a 2 years period, clearly showed that all three, aflibercept, bevacizumab, and ranibizumab, had equal effect if the visual acuity was better than 612. So any one of them can be used. But in case the visual acuity is worse than 612, 20/50 or worse, then in that situation, I think elpiprecept has done much better in 2-year study. If the patient, and these days especially, I have seen after that scheme has come in, which is there with in some of us, so many of these patients do enroll now, and they get much better if their vision is worse. I think they fare much better. I think that is what I think in the morning session I was trying to mention about this one. This is the protocol I, persistence of edema. This is the post hoc analysis which has been done. And 1/3 of these patients experience persistent edema during the first year after initial ranibizumab treatment. That is the strict treatment, which is monthly almost. And in adjusted analysis, gains in vision improvement were lower for these very eyes at 52 as well as 104 weeks. So this is by Sada et al., which has been published in IA2020 here. And that is what is significant, that 1/3 still would have a persistent edema, which is a very important information according to me. So as far as the anti-VEGFs are concerned, early intensive treatment with anti-VEGFs in the first year lead to vision gain and can be maintained over a long period of time, and it may reduce also the treatment burden. We know in subsequent year, if we have not even treated that intensively, the injection required are much less. And aflibercept is the treatment of choice for the worst vision, worse than 20/46/12, if the patient can afford. And this is according to the protocol T, as we have, and is supported by the international guidelines. And approximately 1/3 have persistent DME. I think that is what we have to, or they are refractory to anti-VEGF, which may require alternative treatments like corticosteroid. I think that is what we have to keep in mind. So what is the real world experience in these cases? The number of patients, are so many, diabetes is common. DME patients receive fever injection as compared to the neovascular AMD. That has been everybody's experience because they have multiple problems. These patients miss injections due to various reasons, and most receive suboptimal treatment. And that is how this results in the progressive visual loss and suboptimal outcome. So corticosteroids, we know we have Ozurdex, Iluvien we don't have, we have triamcinolone, and it is indicated in unresponsive to anti-VEGF or chronic DME. Pseudophakic eyes especially, I think we can be more liberal, and lower risk of glaucoma, or those patients who have a low risk of glaucoma or who have a significant cardiovascular risk, we can use it. And I think considered for treatment of refractive DME, especially if the recent cardiovascular event has happened, efficacy is comparable to anti-VEGFs for DME in pseudophakic eyes. This everybody has shown. And as an adjunct in cataract surgery, of course, is an important one. And cataract and intraocular pressure rise can occur in these cases. I'll show you one example here. This 72-year-old lady who is still under treatment with us. He has received 9 Lucentis and a lot of focal grade, had MI and stenting in between. An happy lady, 624, 636. So she was like a recalcitrant DME like this. We offered her Ozurdex in both eyes. You can see the Ozurdex has been given. She improved remarkably. The entire fluid went away, which she was not going with anti-VEGF at all. And obviously, it did recur, and we gave second injection. I think she has already received by now. She's receiving fourth injection each eye. And I think she's doing very well and is happy with the treatment. So the study here has already concluded that treatment with Ozurdex is associated with a significant improvement in visual acuity of 4 lines, 20 ETDS letter in cases of DME refractive to anti-VEGF therapy. That is the way the case I have shown. And what about DME surgery? I think it is beneficial for functional and anatomical outcome. Already highlighted by Professor Atul that ILM peeling in tractional DME is still controversial. We don't know. Some of them, they may lead to thinning of retina later on and do worse outcome. I just sharing one, this lady long time back coming to me and received grit laser treatment earlier, then lot of injections, 6 Avastin, 6 Lucentis, and she was afraid of surgery. All the time she was being told, because she wouldn't, once she worsened, then finally in 2015, she was taken for surgery. And you can imagine how good she still improved 612. So surgery has a place in tractional DME and they do very well. And this was without any ILM peeling, and that is what was done. So there are economics of diabetic retinopathy management, especially in our country. Individual pays for the treatment in our India, as well as insurance cover, and the government support is limited. And the treatment in such cases, which are chronic diseases, the cost and diverse sort of a scenario, we have a problem. So we have to modify. We have to even go sometimes to triamcinolone 2 milligram or something, but we have to treat these patients. And the standard of care with some rider need to be followed. So often the patients are here under-treated and under-monitored. So I would like to conclude my talk with that good metabolic control improves the outcome. I think that we should not forget all the time. We should remind ourselves, we should write down all those investigations which I mentioned in the book. And anti-VEGFs are the first line therapy in center-involved DME. And 1/3 are non-responders or a recalcitrant DME, which may require alternative therapy with steroids or some other therapy, or maybe, I don't know about the combo treatment which talked earlier. Steroid may reduce treatment burden. This we realized during the COVID time, and we gave in some of them steroid Ozurdex injection, and so at least they were good for longer time. And the vitreous surgery is required in tractional DME. Thank you very much for your attention.
Just to start the discussion, sir, what is your take and advice to the ophthalmologists in India regarding brolucizumab? And Professor Vishali also on this, because it's become very controversial, sir, with the Merlin trial and everything.
Yeah, in fact, in the beginning, they did put me also into some of these meetings, which were with the international experts and others from the Novartis side. And you see, especially after this Merlin trial, you see what has happened is after 3 injections, they started having monthly 3 injections, started having so much of problems. That means they had high incidence of inflammation. And even Dr. Vishali would remember when we had a last meeting, and I think in the US, most of them, they are not using at this time, and they are very, very scared of using it. So maybe only in refractory cases at this time, and that also only in neovascular AMD, I would say. In diabetics and in others, I think where already we find maybe they have more chances of inflammation and other things, they might have even worse problem. So I think there is a concern, according to me. I think Dr. Vishali is here and others' opinion. Of course, your own opinion.
Professor Vishali,
I agree, because when we see reports from US, when we hear our US colleagues in meeting and the Merlin trial, the things, inflammation is a serious side effect. But when we hear, like meeting an hour ago, 3,000 injections given in India, no inflammation, go ahead and give, nothing happens in Indian population. Honestly, I'm worried, because I don't know, I don't want to comment, but I would go very slow. And as Dr. Dogra said, only very recalcitrant cases, because I made a comment there also that with AMD, the fluid not resolving, it's the central 500 micron which is going away. And if you end up with a vascular occlusion, you kill the peripheral vision also.
Yes.
I would be very careful.
Exactly. So you won't withhold your treatment with brolucizumab at this stage? Or would you give it in refractory AMD?
Recalcitrant cases, other eye vision is good. After discussing with the patient, we are given.
Rohan, what do you You'd like to say something?
Yes, sir. I would agree. I would agree with what ma'am has said. And
What is people have stopped PDT, but they're busy. Every day you hear some courses being conducted, webinars. So, they're going to push it very hard with all the retina specialists. So, Rohan, what is your?
yes, sir. I would also agree with Sir Dr. Dogra and Ma'am Dr. Vishali that we have to be very careful at present. And even in the pre-operative assessment, we must look if there are any pre-existing anterior chamber cells or any sign of peripheral healed or even healed past vasculitis. Probably that patient is absolutely not a candidate. And we have to see further results of other long-term studies and only then go on with this.
Right. Rajat, you want to say something?
Same.
Can you go on to the next presentation? That's Parjat, it's your presentation.
Yes. So, good afternoon. So I thank Professor Atul Kumar, our chief, for giving us an opportunity to speak in this session. And thank you so much, sir. And under his guidance, we have been able to do and expand a lot of these ROP services at RP Center AIIMS. So I'll be talking to you about ROP surgery. So there are a lot of surgical challenges. Fortunately, at RPC, we have a very strong anesthesia team, a very strong NICU backup, because of which we are able to take these very small babies up for surgery. And obviously, there are a lot of challenges because there are very small eyes. So I'd like to show this photo because this child came to us. As you can see, he's developing stage 4 ROP in both the eyes. He's developing hemorrhage in one of the eyes. He could not be operated for 2 weeks because the child was sick. When he came back for surgery, this is what it looked like. You can see that both the eyes are going into stage 4B ROP now. The traction is lifted. The macula is dragged. The hemorrhage is worse. So what a situation was much easier to operate in the earlier 2 photos has now become much more difficult to operate in these situations. So what you would appreciate that if you delay surgery, the retina is going to pick up more height, it's going to become more peripheral. This is going to make instrument access difficult, making it more difficult to relieve the traction. Moreover, the TRD is going to become more vascular. There'll be more chance of bleed inside, post-op bleeds, complications. If the lens gets involved, then there's a high chance you won't be able to do a lens sparing vitrectomy. If the macula gets involved, then obviously the outcome of the macular pucker will be there and the vision will not be restored as much as you would like it. So how are the results of stage 4 surgery? The results are pretty good if they come in time. As you can see the left photo, there's an extensive TRD developing there. If you do a vitrectomy, all this traction will go away and the retina will appear to be well settled after end of surgery. This is the same photo I showed you earlier. If you can see that there's extensive macular pucker now, although that entire ridge and the TRD and the hemorrhage has gone away. So if you end up with 4B, the macular outcomes might not be so good, although the traction and the pull may go away. This does show you a case of 25G lens sparing vitrectomy. You see now the cutter is relieving the traction of the bands attaching the disc to the TRD. Once you remove the central traction, then there's this vertical traction which is there, which is pulling the TRD into the middle of the vitreous. So you relieve all that traction all around wherever the traction is. You can see it's bleeding because these vessels are growing into the vitreous. So you can go ahead and do diathermy there to all these bleeding vessels once the traction is removed. Just below that, you can see that the circumferential traction we have also cut so that the 2 TRDs on either side of the arcades can fall back. And the circumferential traction is gone and now a localized PVD is being done. So what I just want to show here that there are 3 types of traction which you needed to relieve here. One is this vertical TRD which was developing here. So this we all relieve anyway, but we also need to relieve any kind of tangential or radial traction which is there, which could be in the form of PVD, could be in the form of bands, so that it doesn't close towards the disc. And the third is the circumferential traction, which pulls this multiple TRDs together and tries to close the ring, which also needs to be relieved in time. There's another case where the TRD is more posterior. It's a zone 1 disease. Again, you can see an extensive traction is there. You can see how yellow the vitreous is here. So once you remove all that vitreous, all that, here you can see that all the fresh laser marks have been given just prior to surgery and the GA. And here you can see the yellow vitreous is gone. You can see the macula is also not vascularized here. And the PVD is being done here. So this is how it looks like at 4 weeks. You can see the entire TRD has gone away. The eye is already lasered and the retina has grown further. But it's important to realize that this case still is pretty bad and might not have this kind of outcome and could have just closed into cauliflower shape if we had not intervened. So we need to operate earlier, otherwise you can end up with unpredictable outcomes. Then obviously you have this case, if you refer this case late and keep on praying for the disease to go away, it will not go away. And you see here it's come behind the lens, and the height of the TRD is so much that you can't do a lens sparing surgery. Professor Dogra has popularized this all nasal approach for cases with stage 4B ROP. This is a screenshot from his paper, where he advocates all nasal approach, especially if you've got a stage 4B temporal TRD, where you can go through the nasal route, and this allows instrument access and you can relieve the traction, and these babies can have a good outcome. So this can be tried if you are ending up with stage 4B ROP. This is another case scenario where despite laser, you can see that the TRD is still lifting up, and you can see extensive neovascularization is there. So in these cases, we like to give anti-VEGF at the end of surgery under air, so that further the effect of this can contribute to the regression of the disease. And you can see in this kind of thing, the regression which you see here, this kind of clean regression is only possible when you combine anti-VEGF along with surgery. In these selected cases, it's not needed for all cases, only selected cases where you see extensive neovascularization is there, because and laser is already there, but the traction is still continuing. So this kind of response can be obtained with the combo therapy. Many times you see bilateral cases coming in. So in these cases, it is a good idea to do bilateral surgery simultaneously. It's probably one of the few situations in ophthalmology where you can try bilateral surgery. Obviously, we treat both the eyes as two separate surgeries, and all kinds of precautions are taken. The fluids are changed, the instruments are changed, the team rewashes again. Very important to treat it as a second surgery. It also minimizes high risk exposure to GA, which is a major risk factors in these babies. And obviously parent counseling becomes very important in these babies, because the parents need to understand why you are doing a bilateral surgery in one sitting. Just a quick word on complications for newcomers who start into ROP surgery. They sometimes have difficulty in gauging the size of the eye. The eyes are very small. If you insert the full trocar cannula system into the eye, there's a very high chance you might end up with a break, and it might hit the retina, hit the optic nerve. So it's very important to realize that these eyes are very small. So you don't insert the cannula in full, don't insert the trocar in full, and you take it on time. If you land up with the retinal break, there's nothing to worry. You just go ahead and laser it very well, and it'll just the scarring will happen later. Don't do a PVD there. Don't try to manipulate the tissue there. Put oil, gas. That is really not needed in an attached retina. Many times the eyes are very small, and the cannula can twist while movement, and it can lead to a lens touch. So if the capsule is intact, you don't need to actually go and remove the lens. Just a small opaquity will stay in the periphery. Obviously, if a posterior capsule tear has happened, or if a cataract is developing intraop, then obviously you need to remove the lens. This is another problem which happens, suprachoroidal fluid misdirection. Again, you see all the problems are mostly happening because of a small eye and difficulty of instrument access. So sometimes if the eye is small and your instruments gets misdirected, fluid can glow into suprachoroidal space. So again, you don't need to worry. Just put air inside, let the fluid come out naturally from the subcon space, and the outcomes can be good later as well. And obviously post-op hemorrhage, intraop hemorrhage are very common complications. So don't leave bleeders in the end. If you cut too much tissue, do remember to diathermize it to reduce the IOP&C. Sometimes the machine, because of high IOP, does not let the bleeders bleed. So it's important to reduce the IOP&C if the bleeders are bleeding. Unfortunately, stage 5 ROP is a very bad situation to be in for the parents, the child as well. Unfortunately, we get a large number of stage 5 babies coming to RP center. Around 5 to 7 babies come every week, and they are almost blind. They have never been screened. Professor Atul Kumar published this excellent new paper of the management of vitreoretinal surgery during the COVID times, and how it impacted the services at RP center and throughout India as well, and how we can improve during COVID management in these strategies. Just to show you how the management varies in stage 5 ROP, and there are different kinds of traction which happens, from ridge to ora, ridge to ridge traction, ridge to lens tractions happen. So this helps us to understand how surgery in stage 5 ROP is a little different from routine vitreoretinal surgery. If we need to release all these attachments which are there, then only these cases can be successfully operated. Obviously, ultrasound is a useful tool in these, and if you have an open funnel, that's a good situation to get into. If you have an absolutely closed funnel situation, then it's not a good idea, and the outcomes might not be as good as expected. So just to show you the technique of how we like to operate stage 5 ROP, this is a 23G MVR going in through the clear corneal approach, and through these 25G instruments are put in. And here you can see the 3 instruments have gone in. So it's a clear corneal approach. Later it allows for sutureless closure. Now you can see lensectomies have done, all the sine K, all the membranes are removing. Now the lens is gone. So this is the retrolental membrane where an opening is being made in the retrolental tissue. So you have to be careful that you don't hit the retina, which is immediately behind this. And once you can remove all this tissue, then a large opening will be available. So this is a case of open funnel configuration. So you can see that we can safely try to open this funnel. And as we continue to dissect, this tissue does tend to open up. And as you keep going deeper and deeper, you can see more and more tissue can be dissected away, and the central funnel tends to open. So therefore, we believe a trial for stage 5 surgery should be given in these cases, because there is hope that some of these cases might open up well. There you can see the disc is there, the posterior pole is there. Posterior pole appears to be almost shallow attached. And here you can see that the wound can be hydrated and air comes in the end. And you can end up with a sutureless closure in these eyes. Here's another case operated, and this is how it comes. It's not to say that stage 5 has a good prognosis. Stage 5 has a universally poor prognosis. What I'm trying to say is that surgery can be tried in stage 5 ROP. Some of these cases do open up, and if they get navigational vision, then they can recognize that there's a table here. They can see shadows. They can go to the toilet on their own, not crash while walking. They can recognize the parents are in front of them, and a social smile might come. So all this can really change the life of the babies, although the vision might not be very good. So we should attempt surgery in these cases. So thank you so much. Sir, your mic is muted, sir.
So you're muted.
What is your advice to the beginner ophthalmologists, the residents, that why is the incidence of ROP less in large institutions like PGI and AIMS as compared to other smaller centers?
So basically it's happening because
what can they do?
So basically it's a disease which is being generated in the NICU. Sir, institutions like AIMS, PGI have very good NICU care. So they take care of a lot of parameters like oxygen saturation and best practices in blood transfusion, control of infections, sepsis, etc. So these best practices are not being followed in a lot of other NICUs where these babies are there and they're exposed to hyperoxia, uncontrolled risk factors, and all this leads to severity of ROP coming in these areas. So if you have a factory of AP ROP which is generating ROP every day in these babies, we should go back to the NICUs and see what the problem is. So the focus first should be on the NICU which is generating ROP, and once we deal with that, then we can come to the ophthalmologist side and train them.
So, would you like to say something? I'd like to hear about the all nasal approach, sir.
I'm so thankful. I'm so thankful to Parijat. He kind of brought it out here, and I really would like him as well as Rohan to try it out in some cases. And because all techniques which you kind of do first time, you need to further evaluate. It's only that once it will stand the test of time that it will come into. And but I'm happy that some people have tried it even in the Western world. So some talk to me because it got published in Retina, so that it has. So they did feel that it did help in some cases. So let's see how it goes. So I'm happy, but I must congratulate Parijat for excellent surgery, excellent work he's doing. I have one question for him, quick. I think the time is over. What about this? When do you give this anti-VEGF before surgery?
So we give it intra-op. The cases which I showed, we give it intra-op at the end of surgery. Okay. Under air, we inject half dose using a green tip cannula. So it's a combined approach, same intra-op.
Okay, thank you. Great, absolutely.
What's the choice of anti-VEGF, sir? What are anti-VEGF do you
So
anti-VEGF. What anti-VEGF would you prefer, sir? Usually they're giving Avastin. Because I've heard of reports of Lucentis also.
Yeah, we are giving at this time, you see, eccentrics, because that is one which is approved. So we don't want to land into trouble because of that part. So that's why I think it is because of the rainbow trial, which has kind of widely now used, and approvals have come in various continents. So that's how probably we have to go that way, because we have to be much safer from that point.
Medical legal issues.
Yes, yes.
Because I think some crores of rupees have been granted.
Yes, yes, absolutely.
Could we have Professor Vishali Gupta's talk, please? Madam.
Thank you, sir. Thank you for the opportunity. And, it's one of the probably last sessions of the day, but it's so much full of variety that it's keeping all of us totally glued to the screen. So topic which Professor Atul gave me is about macular choroiditis, how to suspect and manage. The first question was how to suspect and when to suspect. It's very simple. Choroiditis is deep. You can see overlying vessels very clearly. And because of the sheer anatomy of the choroid, the choroiditis is going to have a kind of expression. It can be either unifocal or multifocal or diffuse. And this is the example of multifocal, where you see many patches of choroiditis, which over a period of time may become confluent and form a diffuse kind of choroiditis. Sometimes, especially for the beginner and the students, if you are in doubt whether it is a choroiditis or retinitis, it's always a good idea to look at the OCT and fluorescein. Choroiditis is always hypo in the early phase, becoming hyper in the late phase, and may have a pocket of fluid or serous detachment associated with it. Do OCT, and OCT would show you the choroiditis where choroid is primarily involved. For example, in this patient who has a choroidal granuloma, you can see the choroid elevated, and you can see on response to response to therapy coming back. The changes which are happening in the retina are mostly in the outer retina, and they overlie an area of choroidal bump, which is seen very well on OCT. Now, when should you not suspect choroiditis? One, if you are seeing the lesion which is fluffy white, which is obscuring the vessels, which is margins are not so distinct, and there may be overlying vitritis. Now, this is the kind of the lesion which is retinitis. So please do not think of the differential diagnosis of choroiditis in these lesions. So what should you do if you are in doubt? Just do an OCT, and here the OCT shows beautifully that there is involvement of inner retina primarily, and whatever is happening in the choroid, it's a kind of secondary to the retina and not the other way around that we saw in choroiditis. Fluorescein angiography may show hyper to increasing hyper, but it's not as characteristic as in choroiditis. Why is it important to know? Now look at this patient. The patient presented to original ophthalmologist with this lesion. At this time, he was labeled as choroiditis, treated with steroids, and by the time he came to us, he had a diffuse lesion like this. We actually did a vitrectomy because it was so confusing at that particular time, and it was toxoplasmosis. So if this had been recognized as toxoplasmosis, it's just a clinical diagnosis. You would have saved the vision in this particular eye with very simple, straightforward treatment. When not to expect is when you have these subretinal deposits, which have a linear configuration like this. For example, this patient was diagnosed as TB choroiditis and was treated with anti-TB drugs and high-dose steroids. So patient came to us after 3 months of the treatment with the reason that she's not responding to therapy. Now, if we look at the configuration, this is not how the choroidal architecture would be. This is not how the anatomy of the choroid will be. So choroiditis is not going to be linear like this. This was the nasal, which again showed subretinal fibrin. And of course, the fluorescein confirmed that it was central serous chorioretinopathy, which was multifocal. We just stopped steroids and everything, and the patient responded. Now, I was kind of intrigued. Was it TB to begin with and then steroids induced CSC? Or was it just a fibrinous variety of CSC that was confused by the ophthalmologist as TB? So I asked him to get his previous pictures, and as you can see, before starting treatment, he had these lesions, which were increasing hyperfluorescent dots. So this is not the fluorescein or the clinical picture of choroiditis. So these things are very, very distinct and should not be confused. Then comes sometimes a subretinal deposit. So if you have a subretinal deposit, please do not suspect choroiditis, because these are the ones which are going to be masquerade. Now this patient had leukemia. Subretinal deposits like this one, again, if on OCT you are seeing something beneath the RPE, again, never ever think of the differentials of choroiditis. These are the patients who are very likely to have lymphomas or other masquerades. So now is that you have suspected the choroiditis, but what do you do next? So once you are sure that it is choroiditis, there is important to know that in choroiditis, there is a very close call between being infective versus non-infective. So you ask yourself a couple of questions, which I have listed here. Is it choroiditis or retinochoroiditis? OCT, fluorescein, and of course your clinical judgment would help. Is there associated involvement of optic nerve head or retinal vessel? Do these clinical features fit into any of the entities that you know of? Pay attention to associated anterior segment inflammation, vitritis, associated CNVs. Is it unifocal, multifocal, unilateral, bilateral? Any systemic disease? And is it recurrent? What is very important, if it is recurrent, what was the previous episode like? And is it responding the way it should be responding? I gave you this example. Now let's see how this algorithm fits into it. This is a 29-year-old lady. She had received intravitreal triamcinolone, oral steroids, ATT, for almost 8 months. And when she came to us, her visual acuity was counting finger. Well, is it retinochoroiditis? Well, this is retinochoroiditis. It's not choroiditis primarily. There was associated vitritis. It's an immune competent patient and it's unilateral disease. But what is very important is to ask patients and to spend some time, because by and large, they are carrying this huge file with them and we are impatient people. We don't even look at it. We say, okay, forget it. Go and get your ICG and OCT done. No. If you are in uveitis, that file, some one page in that file may give you the entire story. So what was the past episode like? You just look at the past episode and you look at it and you say, oh, this is toxo. Otherwise, if I had not seen the past episode, I would go with viral lymphoma and, so many other possibilities in mind. And of course, as I told you, her past episode, actually we saw it much later. Before that, she had already undergone a diagnostic vitrectomy because we had a huge list of differentials, and her vitreous shows a cyst of toxo sitting there. Just a last case to show an example of how to work up these patients. A 27-year-old man, decreased vision, sudden onset, painless, progressive. He also had some complaints about redness and pain for the 6 days after the onset of decreased vision. So we look at it, we know it is choroiditis, there is vitritis, there is peripapillary involvement. Choroiditis is multifocal, it's unilateral. Now, what is that episode of pain? He has a component of scleritis to it. Now, scleritis with choroiditis, multifocal choroiditis, vitritis, scleritis, you tend to think more about infective than non-infective, and TB will top the list. So we do the ICG fluorescein just to document the activity and the lesion and the extent. And of course, the ICG shows very classical serpiginous-like choroiditis. And Montius is very significantly positive. Quantiferon is positive. On CT chest, he has some mediastinal load, nodes, and EBUS is positive for TB. So this is how the diagnosis can be made by using very simple algorithms, and you can see good response to treatment. So in nutshell, if it is choroiditis, look whether it is diffuse or multifocal. If it is diffuse, if it is primarily retina involvement, it could be toxo or viral. If it is primarily choroidal involvement and looks like serpiginous, rule out all the causes for infective, but in the meantime, be careful that it could just be an autoimmune variety which has a very different phenotype. Yeah, I'm just finishing. If it is multifocal, there could be a very classic phenotype, pick, mutes, ampy. There is no need to investigate these classic phenotypes because they are very classical. Investigate only if patient is not responding. However, anytime you see a atypical phenotype which doesn't fit, always investigate these patients with choroiditis. Thank you very much, and thank you, sir, once again for the kind invite. Sir, you are muted.
Thank you for an excellent lecture and beautiful pictures. Very, they actually illustrated the whole disease themselves. So you had do excellent documentation, and the diseases were well explained by you. And so, as usual, so it's always a treat to listen to Professor Vaishali. And anybody has any queries? Rohan?
I would like to say very excellent photographs and excellent presentation, and such nicely explained, ma'am, for all the postgraduates and residents who must be listening. It's an excellent demonstration and of how to distinguish choroiditis, retinitis, and how to go about these cases. One thing I might, if might add, sometimes when we see very small choroiditis lesions at the posterior pole, I have seen some residents, they confuse it between idiopathic choroidal neovascular membranes and choroiditis. If you could tell us something which we can do to distinguish between them.
Even in our setup, healed choroiditis patches can have an underlying membrane, which we are now exploring more and more. So I rely on OCTA in these patients because, you know, with fluorescein, there is so much happening with the choroiditis scars that it's very difficult to delineate a small membrane. So whenever in doubt, I will go for OCT angio, make sure the segmentation and everything is appropriate, and then try to look for a membrane.
Thank you, ma'am.
Okay. We'll go to the last presenter. This is Dr. Rohan Chawla. He's going to talk about diabetic retinopathy and surgery for DR.
Thank you, sir. I would like to thank Professor Atul, sir, for giving me this opportunity in this very interesting instruction course. So I hope my screen is visible.
Yes, visible.
So I'll be speaking on diabetic vitreoretinal surgery. So indications, all of us know. I would not go too much into that. I would start off with the preoperative planning and the surgery itself. So we have seen that a laser diabetic is definitely easier to operate. If the systemic control of the patient is better, the patient on table performs better, the surgery is easier. So and if patient is on dialysis, it's a good idea to get the dialysis done prior to the surgery, and the anticoagulant should be adjusted according to the physician's discretion. It is better to give preoperative anti-VEGFs, and I have started giving them in almost all my complicated cases at least. And if the case is less complicated, even a day prior is enough. Otherwise, better to give it, and it should stay in the eye for 3 to 4 days. If there is a significant cataract, then depending on your surgical capabilities, you could get the cataract removed prior to it, or you can do it in the same sitting. The most important thing in diabetic surgery is identification of the planes. And the first plane is the plane of the posterior highlight. So if the posterior hyaloid is already present, it is an easier surgery. Otherwise, we should identify where it is present and try to make an opening in it. And through it, if there is subhyaloid blood present, drain it and then extend that opening 360 degrees. So here, as I have marked with these arrows, here is the initial opening in the posterior hyaloid that I have made with the cutter. And now I will slowly extend it 360 degrees, and then we'll reach the pre-retinal surface and drain the blood. Now, in certain cases, the hyaloid is attached in a tented manner to the retina, and you can have gaps between the hyaloid, which give you your instrument's access. And these cases are slightly easier to operate as opposed to other cases where the posterior hyaloid is totally plastered to the retina. And here, probably bimanual instrumentation helps to create a plane between the hyaloid and the fibrovascular proliferation and the underlying retina. So to simplify dissection, we can use hybrid surgeries with a 23 gauge port and a 25 gauge and a chandelier. 23 gauge scissors are easier to manipulate for beginners, and then you can shift on to 25 gauge. And the second instrument helps you to hold the front, and you can then insert your scissors in the right plane and prevent injury to the retina. So this is a recent study in which the on-fast OCT analysis showed that the hyaloid is more tightly adherent around the arcades than in the center and the peripapillary area. So, and I also find this that in diabetics, the adhesion is very strong here. So sometimes it is easier to take your scissors inside the central cauldron and then go from inside out and try to create a plane. This is the same on a B scan. So this central area, the adhesions might not be that tight, and you might be able to get a plane there. And so this is called radial segmentation, which can be from inside out or outside in. So you are going directly towards the central fovea and trying to segment these membranes. And also the other thing that you have to do is you have to identify these tiny pegs which are connecting these membranes, and we can cut these pegs to remove them. Bimanual surgery also helps us to stop bleeders. So in one hand, we have the back flush, which can remove the blood, and in the other, we have the cautery, identify the bleeder and instantly cauterize it. Sometimes we can use intraoperative OCT to identify any small breaks. Also, we must know when to stop. If we keep on doing surgery, extensive surgery, we might create more iatrogenic breaks. So it might be a better idea to sometimes leave the nasal proliferation, just clear the disc and macula and end the surgery there. So I'll show you some surgical videos. This is a case with a large prehyaloid hemorrhage. So here we are trying to first create an opening in the tight hyaloid, which is lying over the bleed. You can do it with forceps, you can do it with suction. So once you will have the opening and you can see the sheet coming, and again we are holding it with the forceps, you have to gently remove the sheet. As we remove the sheet, we see that it is further attached to these fibrovascular proliferations at the arcade. So here comes your judgment and your experience. If you feel that the adhesions are strong, then you would rather stop and segment. And if you feel that no, you can pull them off, then you can also delaminate them in one go. So here, some of these pegs I'm cutting with the scissors, and slowly now with the cutter, taking it in an en bloc technique, the entire thing anteriorly, completing the vitrectomy, draining out the blood, and we have a nice healthy posterior pole. Patient would gain good vision. This is a more complicated case where you have a tabletop sort of PRD. So here I'm using bimanual dissection, and like I showed you, just lifting the membrane gently with one hand and trying to create that plane between the fibrovascular membrane and the retina. Just as Professor Parijat showed us beautifully in that case of stage 5 ROP, I think this is something like that dissection, and we have to not try to damage the retina and not try to create more and more iatrogenic breaks, and be gentle, create a central cauldron that I was talking about where the adhesions might not be that strong, and the adhesions are stronger here along the arcades. So a combination of dissection with the cutter and with the scissors helps us to complete such cases. So again, proceeding to segmentation now near the arcades. So we are creating that gap between the retina and the fibrovascular proliferation, and inserting one lip of the scissors under the membrane, using the scissors as a blunt dissector as well, and snipping it into two. So many times you would have the bleeders coming up, and it is a good idea to manage the bleeding at the same time. Just raise the bottle height, the bleeders would stop, and then you can use your bimanual technique or your cautery to stop the bleeders. If we let the bleeding happen, it forms a second membrane, and the second membrane sometimes becomes even more difficult to remove than the primary case itself. So here, without the scissors, I'm now using the cutter itself because I thought there is a gap between the membrane and the retina, and the cutter itself is being used to segment this sort of membrane. So in the end, this is the nasal part which we are just cauterizing. So we are leaving these nasal segments. The disc macula is clear, and again this case can be left just under air. Another such complicated case where the posterior pole is involved with the traction. So first of all, clear the posterior hyaloid and the overlying vitreous. Where you feel there is a gap, you try to create an opening so that you can lift the flap. And once the flap is lifted, then you are better able to appreciate the planes of the retina and the fibrovascular proliferation. And just like I showed you earlier, going that in a radial manner and cutting the membrane from the underlying retina. So the same way, segmenting it. Sometimes we are able to lift off the fibrovascular proliferation directly from the disc also. And it's a good idea to cauterize all the areas where you have cut to avoid postoperative bleeding. Now, in other such case, and in this case, what I wanted to highlight, which I've started doing recently, is also limited ILM peeling. So what I do is that I stain, and if some residual traction is left around the arcades, I just do limited peeling from the fovea towards the arcades. Now you see that because of the fluid under the retina, it's mobile. So the retina is detached. So it has to be a slow process and it has to be carefully done. You don't need to do an extensive peel. And if you can possibly spare the fovea also, but detach the foveal area from the area of your traction. So that I feel makes the retina more mobile, and that lets the retina go back in place. But like sir has mentioned, that I only recently started doing some of these cases, and we have to watch because sometimes ILM peeling can be traumatic also. So just do it when you feel that you need to relax the retina a bit, and then again leave these cases under air. So I can go on and show you more cases, but I think I'll stop the videos here. Sometimes we see that traction is going on till the periphery. So here again, it is a good idea to complete the vitrectomy, remove the posterior membranes first. Sorry, and also gently lift off the membrane from the disc, take it to the periphery and not pull on it too much, segment it with the cutter and leave it. So you see these tractional bands, but you no need to bother, just put air and leave. In some cases where you do land up creating a break, you can use silicone oil as well. But if the break is superior, then you can also get away with gas. So these are some of the cases. This was a type 1 diabetic, extensive proliferation. I could just not leave these, release these areas, but the patient did gain good vision. In other case, with the nasal hyaloid and proliferation is left, but the disc macula is okay. And the patients, such bilaterally blind patients, do get vision by which they can at least manage their daily activities. So the key points are the patient has to be systemically controlled. I prefer using preoperative anti-VEGFs. Proper identification of the planes is the key. Segmentation, delimitation, and en bloc dissection. A combination of these, a combination of a use of scissors, forceps, and cutter helps you manage these cases. And bimanual surgery and slow surgery helps avoiding gas. But yes, in certain cases, silicone oil definitely can be used, and it helps settle many of these retinas. But yes, like all others have stressed, in diabetics, the best idea is a very good systemic control so that the patient doesn't land up in such a situation at all. Thank you. Thank you very much.
For a very nice illustrative lecture on DR surgery and diabetic retinopathy for PDR surgery, where patients have obvious diabetic traction detachment, fibrovascular proliferation, and they're literally blind. And the last year when the COVID came, and this year also, we had a lot of progression of DR. Many patients who were earlier amenable to laser therapy now turned into surgical patients. I mean, requiring surgery, and they really worsened. It was shocking. So to see those patients coming back with the obvious traction and detachment in the macula or threatened macular detachment. So I think surgery has to be very careful, and you have to find the correct plane. So if you find the correct plane between the fibrovascular proliferation and the retina, then you definitely make sure that no breaks occur. So the most important key to any good diabetic vitreous surgery is to find the correct plane. And once you find the correct plane, the cutter can go under it or the scissor, and you can kind of massage a little bit to make sure the membrane is lifted up and then cut, or the cutter lifts up the membrane and then the cutter cuts the membranes. So any thoughts, sir?
No, beautiful.
Thank you, ma'am. Thank you, sir. Thank you.
Very good, very good. Excellent presentation. I think you touched upon most of the things which are so important. And I liked it that you leave most of your patients under air. Or I always used to say, and that was this thing, if you don't use anything, that patient does the best.
Yes.
The second is where you used air. And third would be a gas. And if you have used silicone oil, that is going to do us. So that is because we understand, because it is this very bad case anyway. So I think that's wonderful. And second thing I liked is leaving those eyelids, not being over enthusiastic.
Yes.
And doing and chasing everything, and especially going for the nasal kind of proliferations if they are so tight. I think whatever we can achieve where we have all the surgical objectives achieved, whatever we get, I think I like that kind of approach. I think I want Dr. Vishali to a little bit talk about her proportional reflux, which she uses very often and is very helpful in difficult cases. And
No, I use that just to delineate, but the key factor still remains that you have to find the plane. Once you are in the plane, then instead of using the scissor, you just use this cutter as a scissor with a very, very guarded egress of the liquid, which helps in separating the plane, and you can keep on cutting. Especially with cutters, it's become so easy now to do, single instruments that but as you said, sir, we are having a really increased number of patients in the very advanced form of the disease. And also the patients, like Dr. Dogra mentioned, had silicone oil injected and then could not follow up for months together because of COVID, ending up with INVs and all. So it's a serious, serious problem at hand. But somehow we can't help.
So we finished well in time, and just in time actually. I hope everybody enjoyed the course, because there was a lot of discussion and some good presentation. All the presentations were excellent, and thank you everybody for joining in for this instruction course. And we hope to see you again soon in some meeting. Thank you so much.
Thank you, Mr. Atul, and thank you everybody.
Thank you, sir. Thank you, everyone.
Take care and stay safe.